Hi, I'm Suresh Ramu. I'm the co-founder and CEO of Cytecare Hospitals, Bangalore. I'm delighted to host this coffee conversation with Dr. Prasad Narayanan, medical oncologist. He was a senior director and head of bone marrow transplants, cell therapy, and medical oncology at Cytecare. Dr. Prasad, thank you for joining me today.
Thanks for this, Ramu. I think it's very interesting to have coffee and discuss something very interesting for all of us with you today.
My pleasure. We're talking about CAR T therapy. And there's been a lot of media, there's been a lot of coverage around what is CAR T. And as a layperson, sometimes you wonder if this is the solution for everything, but we sometimes don't understand. We hear words like cell therapy, we hear T cells. Can you simplify this for us to say what is CAR T therapy really?
I think it's very important for us to have this clear, because when we hear about CAR T therapy, the first thing which comes to mind is some sophisticated T cell therapy, immunotherapy. So basically, we want to know what happens in CAR T therapy and why is there an interest in this. So to explain this, I think we should know something about how cancer spreads or why cancer cells are sometimes resistant to many treatments. So we all know that the conventional therapies in cancer care include chemotherapy, surgery, radiation, some radioisotope based therapy. But cancer comes back. So there are many reasons why cancer cells evade uh, different treatments. And one most important thing is called immune evasion, which means every one of us has got an innate immunity. Our body has got cells which are capable of fighting different types of insults like viruses or bacteria or even cancer cells. So T cells are our weapons in this regard. What happens in cancer patients is that with time, the T cells are not capable of fighting the cancer cells. So, immunotherapy and specifically CAR T cell therapy, when you say CAR, it is chimeric antigen receptor T cell. So, we are trying to modify a person's T cells in such a way that they can attack the cancer cells. So, how does it happen in simple terms is that there are certain features which we want to attach or we want to empower the T cells in such a way that the T cell surface is coated with certain receptors. This receptor is the chimeric antigen receptor. When the T cell has got this receptor attached, it can identify a cancer cells and kill it. How it is done, there is a process. I think in due course we can discuss about it. So CAR T cell therapy is chimeric antigen receptor therapy, and it is using the patient's own T cells, modify them in such a way that they can identify the cancer cells and kill them.
So, what I understand is it's using the patient's own T cells. So, do we take the T cells out and then you modify them and then you give them back to the patient? Is that what you do?
Absolutely. So it is a process in which we all know about different ways that we can collect cells from a human. We know about blood donations. We know about platelet donations, or what happens in stem cell transplant, for example, or bone marrow transplant. There is a way we can collect stem cells. Similarly, we can collect T cells also. So there is a process by which the donor, the patient, in this case, the patient himself or herself will go to the blood bank and T cells will be collected. So we will collect a particular required amount of cells. This goes to a lab, and there is a process called expansion where we expand these number of T cells to such a number that is sufficient enough for us to use it as a. It is like creating a drug from the patient's own cells. So we are empowering the patient's immunity by making a drug which is capable of killing the cancer cells. And then this by a complex process, the receptors are attached, and then we have a certain number of empowered cells or CAR T cells which are required, and then they are given back to the patient.
Fantastic. And all this is amazing science. So, this has been around for a long time, or has it been newly discovered? What has happened?
Very
Suddenly?
very good question. I think whenever we talk about cancer, we always think that cancer means low immunity. But oncologists also have been trying to tweak the immunity in some form so that we can fight the cancer with immunotherapy. So, immunotherapy is as old as any other therapy in cancer. So, there have been so many milestone achievements in immunotherapy, and CAR T cell therapy, I would say, is like an end result of a lot of effort which has happened over the last 2 decades or so. So now we can say that we have maybe around 5 years of real experience of success with CAR T cell therapy, which I think is the uh, is the next pillar in treatment of cancer care. And all cell therapies are going to be one of the most important pillars of cancer care. CAR T cell therapy being at the pinnacle at this point of time.
That's fantastic. So, can we treat all cancers with CAR T therapy, or there are very specific cancers that we
So
would have?
this is the question which everybody wants to know. So whenever we talk about a new treatment which is successful, we want to see if that can cure all cancers. So that is not the situation as of now, but that doesn't mean that will not be the situation in the future. So we can take the example of immunotherapy, the checkpoint inhibitors, which are blockbuster treatment in cancer care. They came in the treatment of hematolymphoid malignancies, but now they are used in many solid tumors like lung cancer, head and neck cancer, colorectal cancer. There is role of immunotherapy. Similarly, at present, we have data and we have CAR T cell therapies which are available mostly in hematolymphoid malignancies, which include cancers like leukemia, lymphoma, multiple myeloma. And they are used in the relapsed refractory setting when these patients don't have any other standard therapies which are available. But the kind of responses that these patients are getting, I'm certain that these therapies will come in the earlier stages of treatment, and there are a lot of interest of cell therapy in solid tumors, and we may see that in the next 5 years or so we may have a CAR T cell therapy directed towards each cancer.
Right. So, patients who go through CAR T therapy, do they have long inpatient stays in the hospital? Do they have to stay for a long period of time? Do they become very sick during the process? What actually that happens to the patient? How does the patient go through it?
So I think uh, most of these patients, as of now, the hematolymphoid malignancy patients, have gone through something called as a transplant. They may have gone through an autologous transplant or an allogeneic transplant. So CAR T cell therapy includes few steps. First step is to identify the right patient. We cannot do CAR T cell therapy or any treatment for cancer for all patients. So there are certain factors like a patient related factors, disease related factors, and uh, uh, once we identify the right patient, the next step is to collect the cells. So the patient has to uh, go to the blood bank, just like they go for a blood donation or something, and the patient will have their blood, which is rotating through the stem cell collector or in the blood bank, and the T cells will be collected. It is not just the T cells; the blood will be collected, and there is a program which selects the T cells. So first thing is to count the number of lymphocytes. That is the first step, and there is a benchmark there. So once we reach that, okay, we have collected enough lymphocytes. From the patient's perspective, that is the first step. Once we get adequate number of lymphocytes, then they go to the lab, which I said. So this lab, this facility is important. It's important to have the facility. So the facilities are available in different parts of the world, and in India we have it in Bangalore, in Mumbai, in Chennai. So we have to then the facility has to see how many, what is the adequacy of collection, and once that information comes, then we get the note to go ahead with the expansion process. These are all lab processes. The patient doesn't have to do anything here. So once
Patient has come in, given the blood.
they are then waiting.
Okay.
They are outpatients after that.
Okay. So they're gone home.
They are gone home.
Okay.
And they are not on any treatment also during this period. And once we get this expanded T cell count, that is the time we know that okay, we have collected enough cells. Then the treatment for the patient starts. So then the patient is called back to the hospital. And we have to do something called as T cell depletion, which means now we have to give the patient a kind of low dose chemotherapy. This is like usual whatever chemotherapy we give for cancer, these kind of cancer patients, maybe 20% of the dose. This is not to destroy the cancer cells. This is only to decrease the T cell activity, so that there is no reaction when we give the CAR Ts. So the patient is most probably admitted to the hospital during this period. It can be done as outpatient also. Maybe 3 to 5 days of chemotherapy is given, and now we get the CAR T cell therapy from the CAR T cells, which come from the lab to the hospital or wherever the patient is staying. Then the CAR T cells are infused to the patient. So this whole process, the patient needs almost 1 week in the hospital before the infusion. And once the infusion happens, usually the patient is kept under observation for at least 2 weeks period. And once they are through, they can get discharged. And then there's a disease assessment which happens in a few weeks' time.
Okay, so if I hear you right, patient may be in the hospital for 2 to 3 weeks,
Right.
and very little treatment before, about 5 days of low dose chemotherapy before the infusion.
Right.
The infusion itself is 1 or 2 doses. Sometimes I heard some of these CAR Ts are multi-dose
Right.
therapies.
So some of them are multi-dose, most of them are single dose. So the infusion, the infusion process takes less than half an hour. So all this is for that period actually. So it is given in a controlled atmosphere, and a competent team is necessary to monitor the patient.
So it sounds very different to the chemotherapy or radiation. Maybe a few minutes on how different is it to the other traditional forms of treatment?
Right. So traditional forms of cancer treatment is based on cell kill. So how do we plan chemotherapy or radiation or even surgical removal? That is based on what is the maximum tolerated dose for a patient to get that. So we are now moving away from that concept in cancer care. This is not only regarding CAR T therapy or any systemic therapy. It is even in surgical treatment. Like it is not as if we want to go ahead and remove maximum volume of tumor. We are in an era of conservation. We try to conserve the voice box. We try to conserve the breast, like that. So, but what are we talking about in immunotherapy is that we don't want to give maximum tolerated dose. We are talking about minimum effective therapies. What is the minimum treatment we can give to get the same outcome? So CAR T cell therapy or any immunotherapy for that matter is to tweak the immunity of the patient to a level where there is a balance which happens between the immune cells of the patient and the cancer, so that there can be a persistent action which is not to kill the cell, but it is to have a maintenance in terms of boosting the patient's immunity to fight the cancer.
So it's obviously what you said in the beginning was patients have been already treated most likely, and many of them are post-transplant, bone marrow transplant. So the patients have gone through a lot of treatment already. So it's not like we are replacing those initial treatments yet, at least, as you said. Maybe
Right.
in the future it could.
So that is true. Any treatment for cancer comes like that. But once we have our hands on in this treatment and we have experience about how effective and safe these treatments are, definitely it will move to the earlier stages. To take this discussion ahead, if you take leukemia treatment, the CAR T cell approval is initially for patients who have failed a transplant, but now the approval is almost in patients who have not got a maximum response to the initial chemotherapy. So there are patients who go for CAR T therapy before transplant.
Right. So, and do you have any global data or statistics? Because in India, of course, we've started the treatment now, but is there any data available of how effective CAR T is, how safe CAR T is? Any statistics around this whole
Of
treatment?
course. So why is there an interest among oncology community in this? That is because of the unprecedented responses which we have seen. So when we talk about these patients, a patient who is multiple myeloma who has relapsed after 2 transplants, or a patient with leukemia or lymphoma who has failed a transplant, otherwise we are looking at a difficult to situation where there are not many effective therapies. In this situation, CAR T cell therapy has given responses in to the tune of 70, 80, 90%. And now we have 5-year data outcome where some patients or a large majority of these patients are not relapsing. So from a no treatment situation, we are talking about long-term survival, and that is incredible with this therapy. And the kind of uh, improvements which has happened in the knowledge or the learning curve of CAR T therapy is now almost over, and we know how to do this treatment safely and in the most effective manner for the right patient.
This sounds magical, right? I mean, this is sounding like there are no treatment options for a patient, and you select the patient correctly, you may actually see a complete remission or complete response for patients. Sounds very expensive. Is it going to be very expensive for patients because of this?
Right. So everything is expensive when it starts because the amount of research which is put in behind makes the treatment slightly. But the CAR T therapy technology is now available in India, and we are able to do CAR T therapies in our country for 20% of the cost, which is for the which is global actually.
So you're saying we could do it at 1/5 of what it would cost in the United States
Absolutely.
or Europe or of some of the countries where CAR-T has been done for a while?
Yes. So the cost in India is 1/5 of the cost abroad, and the waiting list in India is lesser than the waiting list there. Actually.
Okay, okay. And so this whole high cost, though it is 1/5, I hear that it is still quite expensive for Indians in India to be able to afford. But if it is obviously giving you this kind of dramatic results, I'm sure there are many patients who are looking for this treatment. Or maybe there are patients who are already traveling outside of India who could look for this. But do you also see patients coming from outside India to take this treatment now in Cytecare Bangalore?
Absolutely. So all what you said has happened. So initially there was inquiry from India abroad to get into clinical trials. We got clinical trials in India, and there were patients whom we could recruit. We have in our hospital itself, we have recruited patients for clinical trial and with extremely good outcomes. We have patients who have come from abroad to take treatment here who don't have a CAR T approved in their country, and there are so many other uh, uh, logistic reasons why sometimes patients are not able to access CAR T therapy in other countries, which I think India being a hub in terms of biomedical research and the kind of facilities that we have a lot of transplant centers. We have centers like us who can take care of any of the requirement which is required for a complex treatment like a CAR T therapy.
So, does it have a lot of side effects? Because you mentioned the complexity of treatment. Do patients go through side effects? You mentioned a case where the patient comes in, gets 3 weeks they're out. But do we need to anticipate or prepare because not all centers can handle the complexities?
Absolutely. I don't think that all centers can handle this complexity. This needs a team which who has got good experience in handling hematolymphoid malignancies in general and transplant patients in particular. So the treatment is complex. At each step, there are bottlenecks actually, and unless you have a team which is experienced in handling this and where we can anticipate these potential issues and they are taken care, there can be problems. So one of the most serious toxicity of CAR T cell therapy happens during the infusion itself. So there is something known as cytokine release syndrome. So this term is now popular after the COVID actually. So cytokine release syndrome can happen during CAR T therapy. It can sometimes be subclinical. So you may not see a very clinically evident cytokine release, but some we have to do some biomarker test to identify a subclinical cytokine release syndrome, which may need treatment. Untreated, it can cause serious issues. So it is not that these treatments are can be given anywhere, and it needs a team which is experienced in handling the side effects. And then the chemotherapy induced side effects can happen. Some long-term T cell depletion, we have to monitor the immunoglobulin level. So there are certain factors which have to be monitored, and a team which has got experience in handling hematolymphoid malignancies and transplant is required for this.
Okay. So patients who have gone through CAR T therapy and let's say 3-4 weeks down the line, and they come back for a scan, and you know, is there something that they have to do in terms of lifestyle before the CAR T treatment, during the CAR T treatment in the hospital, and after they get discharged?
I think it's a good question. So these patients have gone through treatment before. As of now, whatever patients are coming in, so they know about certain do's and don'ts, like avoiding large crowds, not getting a, like now there is a viral fever which is all over the country. So if something like that happens, they are vulnerable to get it. So getting avoiding these things, maybe masking in public in during this period of time is important. But it is not as if this treatment is very difficult also. Many patients whom we have done CAR T therapy have said that this was much simpler than the chemotherapy itself which they have gone through. Forget the transplant. The autologous transplant involves high dose chemotherapy. So they have anticipated much more complex side effects, and they have all not experienced anything like that.
Right. And so it sounds like there could be some side effects that they need to be prepared with. But overall, it is less than what they have already gone through, probably in their prior treatments before they're being offered CAR T.
Absolutely. The immediate and short term, definitely the side effect profile, this treatment is much safer than most of the treatments which is available for
So
cancer.
I want to ask you about, how does a patient out there or a family member out there select CAR T, or decide that maybe they should consider CAR T? What is their decision making process? I mean, and where do they go for treatment? I mean, is there a way that they can say, okay, I should go to, as you mentioned, the team and stuff? But how do a layperson out there who's going through treatment in another center decide that maybe it's a time for getting a review of whether they need CAR T or they could benefit from CAR T?
I think the awareness is the key. The awareness that there is a treatment like this which is available, and what are the implications of taking such treatment. That is the key thing. I mean, all patients nowadays are well informed. They are seeking information. There are websites. For example, our hospital website itself gives in detail about what are the situations where a CAR T cell therapy can be an option for them. There are other websites also which can be looked at, but getting the correct information is very crucial here. So the patient selection is the most important thing in getting the best outcome for any of such therapies.
And is there a difference between doing CAR T, say at Cytecare, to doing CAR T somewhere in a cancer center in the United States of America?
So, as I told you, this is a complex therapy. This involves multiple teams. We need to have a blood bank team which can make sure that the collection happens safely and adequately. The checkpoints from the lab, the hemato-oncology lab has to tell us whether the lymphocyte count is adequate. We need to be in a city like Bangalore where we have the facility where we can immediately know whether the collection is adequate. Then once the expansion happens, the shipping. So being a metro like Bangalore, where we can do all these things in a much better way, makes us a good center to be chosen for this therapy.
Yeah. But is it like, are there certain disadvantages or advantages of doing it outside of what you mentioned? You compare what is available in India versus what is available already in the Western world. Are there differences in the CAR T therapies that are available yet, or anything on the advancement side maybe?
There are no direct comparisons between these, but the outcomes what we have seen with the Indian data is as good as the Western data, and even in the clinical trial scenario as well as in the practice scenario which we have seen. So I would not say that there is any difference here. And most importantly, this is like a drug which is being prepared from the patient's own cell. So that is the key here. It is not as if there is a drug which is prepared and then we are making a biosimilar out of it.
Can you expand a little bit on the research side? You mentioned that there is some research happening on the CAR T. Is it there are more CAR T therapies that are coming in the future? Because you said that this is limited to certain types of cancers at this point.
Yeah.
Are there other CAR Ts or other cell therapies?
As of now, the CAR T cells, as I told you, are focused on certain particular CAR T therapies which are available. But there are newer techniques. we are looking at the possibility of allogeneic CAR T cell therapy. That will change the way we are looking at it completely, actually. And there is something called natural killer cells. So there is a research where we are also part of, where we are looking at something to make a CAR T therapy with natural. So I think cell therapy itself is becoming one a complete stream of innovation in cancer care.
Amazing. So I think you already mentioned that you have information, but we can go to the Cytecare website to get a lot more information about CAR T therapy. I think we have a lot of resources that are uploaded out there so that we can pick it up. And Dr. Prasad is contactable via the Cytecare website. But we're very, very delighted that we were able to do this conversation. I think a lot of patients that we encounter are seeking information about CAR T. So thank you, Dr. Prasad, for
Thanks a
spending so
lot.
much
It was a nice
pleasure. Thank you so much.
thanks.